During this session, we will walk through a condensed summary of care for nursing home residents. This review will serve as an overview. There are 4 session objectives for this overview. First, to understand the demographics and characteristics of nursing home residents. Secondly, to identify risk factors for nursing home admission. Third, to recognize the physician's clinical, ethical, and legal responsibilities to nursing home residents. Lastly, to describe critical elements of resident assessment and care planning. Within the nursing home population, pre-COVID data from 2019 shows that functional disability is common among residents. 90% need help with 3 activities of daily living, or ADLs. 59% need assistance with eating. 32.5% require mechanically altered diets. Over 60% are incontinent. 33% have hearing and visual impairments. 8.8% can walk without help, and 65.8% rely on a wheelchair for mobility. Chronic disease conditions are also a concern. 40% have heart failure or ischemic disease. 22% have diabetes. 26% have a history of stroke. 63% have moderate to severe cognitive impairment. 20 to 25% experience depression, and 33% have behavioral issues. There has been a shift in post-acute care to the nursing home setting because of shorter hospital stays and higher care needs in aging adults. For certain patient populations, some studies suggest that post-acute care in nursing homes results in outcomes equal to or better than in acute care hospitals. However, definitions and regulatory standards vary widely, making comparisons difficult. Post-acute nursing home care combines acute medical care, long-term nursing, and rehabilitation. Nursing home services vary by location and may include dialysis, ventilator support, wound management, orthopedic, post-operative, and rehabilitative care. A few points to highlight about the Medicare Skilled Nursing Home Payment Model. A 3-day qualifying event is required. The first 20 days are fully covered, and days 21 to 100 require copayment. Stays beyond 100 days are not covered by Medicare. Payments are based on the resident's functional needs and rehabilitation potential. The Prospective Payment System, or PPS, requires careful documentation of functional gains, particularly by rehabilitation therapists. The PPS has not resulted in limited access to skilled nursing care, but has made nursing homes more diligent with admission policies. Physical, occupational, and speech therapies are commonly prescribed, with half of all patients receiving at least 90 minutes of these services. The range of long-term care services available, from home care, assisted living to skilled nursing, increases the complexity of patient placement decisions. The use of formal community services does not necessarily reduce the likelihood of nursing home placement for patients with severe disabilities. Of note, education and caregiver support can delay nursing home placement for patients with dementia by up to a year. Some of the factors for placing an individual in a nursing home include increasing age, low income, low social activity, poor family support, and cognitive and functional impairment. Nursing home residents account for over 2.2 million emergency department visits annually in the United States. In 2011, 1/4 of Medicare nursing home residents experienced hospitalizations. 5 conditions account for most resident rehospitalizations, including congestive heart failure, respiratory infection, urinary tract infection, sepsis, and electrolyte imbalances. Nurse practitioners and physician assistants working with primary care physicians can help reduce these hospitalization rates. Challenges with transfers between acute and long-term care facilities include missing or illegible transfer summaries, medication reconciliation discrepancies, undocumented advance directives, and unreported psychosocial issues. The geriatric assessment evaluates many aspects of a patient's life, including physical, cognitive, psychological, and social domains. The goal is wellness and independent function across all care settings. The geriatric assessment should be performance-based and include historical information. Also, efficient strategies are needed for routine office practice. Geriatric patients should complete both cognitive and psychological assessment. Prior to assessment, it needs to be determined whether the individual needs a translator, has vision or hearing impairments that could impact the testing, and assure that family and historical information is readily available. Note that older individuals are at an elevated risk for depressive symptoms, warranting proactive screening and prompt initiation of treatment. Screen residents with the PHQ-2 and further evaluate if necessary. Watch for signs of anxiety and prolonged bereavement. There is a high risk for accidents, delirium, medical non-adherence, and disability in cognitively impaired older persons. The psychological assessment includes physical, cognitive, psychological, and social function. When assessing for quality of life, you should assess using questions about overall and health-related quality of life. The SF-36 Help Survey is one tool that can be used. Age-friendly care may be a more appropriate approach to assess for quality of life by using the 4 M's that include what matters, medication, mentation, and mobility. The Omnibus Budget Reconciliation Act requires monthly medication reviews by a pharmacist. Medications must be medically necessary, appropriately monitored, and not cause adverse effects. A facility must ensure the medication error rate is below 5% and that no significant errors occur. Residents without a history of antipsychotic drug use should not be treated with antipsychotic medication unless required for a specific diagnosed condition. Psychoactive medications require gradual dose reductions unless contraindicated. Advanced care planning involves discussing and documenting an individual's healthcare preferences, values, and goals for future medical decisions. These conversations should include the individual, their family, and key healthcare providers, and be revisited periodically, especially when health conditions change. Designating a trusted person as a healthcare proxy ensures that decisions align with the individual's wishes if they become unable to communicate. It's important to approach these discussions with sensitivity to everyone's readiness and desired level of information, and to document the outcomes clearly for future reference. The U.S. is the only country requiring a nursing home medical director. Certified medical directors are an independent predictor of quality in our country's nursing homes. The role of the nursing home medical director is as follows: to coordinate medical care, set quality standards, ensure compliance with guidelines, and foster team care. Certification is offered by the Society for Post-Acute and Long-Term Medicine, or AMDA. Physicians are required to conduct initial comprehensive visits for newly admitted residents needing skilled care, adhering to state and federal regulations. For long-term care residents not requiring skilled care, nurse practitioners may perform these initial visits. Subsequent evaluations must occur every 30 days for the first 90 days and at least every 60 days thereafter, with non-physician providers alternating visits. Additional visits are necessary for acute medical issues or changes in a resident's condition. Having on-site medical providers enhances timely acute care and can reduce hospitalization rates. Enhancing physician practice in nursing homes involves coordinated care among physicians, nurse practitioners, and physician assistants, which can lead to more intensive care and potentially lower hospitalization rates without increasing costs. Effective strategies include efficient scheduling, thorough documentation of interventions, and collaboration with the interdisciplinary team. Physicians' responsibilities encompass comprehensive assessments, care plan development, chronic health monitoring, acute problem evaluation, team communication, medication reviews with pharmacists, optimizing residents' quality of life and function, assessing decision-making capacity, and establishing advance directives. Residents with delirium require careful monitoring because they are at risk for various complications. Here are some effective management strategies for individuals with delirium. Identify and treat reversible contributors. Optimize medications. Treat infections, pain, fluid balance disorders, and sensory deprivation. Maintain behavioral control through interventions. Monitor for triggers, review family and medical history, and include family members. Anticipate and prevent complications, for example, incontinence, immobility, falls, pressure ulcers, sleep disturbances, and feeding disorders. Restore function through hospital environment adjustments, cognitive reconditioning, ADL status improvement, family education, and discharge planning. Additionally, avoid physical or pharmacologic restraints if possible. If necessary for agitation, consider low-dose high-potency antipsychotics like haloperidol, ensuring a stop date. These drugs are contraindicated in Parkinson's disease, Lewy body dementia, or with a history of neuroleptic malignant syndrome. Drugs to use with caution or avoid are listed here: alcohol, anticholinergics, anticonvulsants, certain antidepressants, antihistamines, antiparkinsonian agents, barbiturates, benzodiazepines, chloral hydrate, histamine 2 blockers, non-benzodiazepine hypnotics, and opioid analgesics. There are a few key characteristics to note about delirium. It often coexists with dementia in older nursing home residents. Distinguishing signs of delirium include acute onset, cognitive fluctuations, impaired consciousness and attention, fluctuating alertness, and altered sleep cycles. Delirium's onset is acute, while dementia is chronic, leading to progressive cognitive decline. Providers should search for underlying dementia once delirium is resolved. There are some notable caveats with medication management for residents with delirium. The resident should be assessed for akathisia and extrapyramidal symptoms, or EPS. In Parkinson's disease or Lewy body dementia, second-generation antipsychotics with fewer EPS effects, for example, quetiapine, should be used. The resident should be monitored for QT interval prolongation, torsade de pointes, neuroleptic malignant syndrome, and withdrawal dyskinesias. Benzodiazepines can be used for a sedative in alcohol withdrawal and history of neuroleptic malignant syndrome. A 2016 meta-analysis found no significant effect of prophylactic antipsychotics on ICU or hospital length of stay or mortality. The decision to use antipsychotics should balance symptom relief against the risk of complications. Antipsychotics should not replace other evaluation and management practices. The differences between dementia and depression are that dementia is a cognitive decline, which may minimize cognitive losses, and depression shows motivation during testing and cognitive complaints exceed measured deficits. With depression, the resident's language and motor skills are intact. About 50% of patients with reversible dementia and depression progress to dementia within 5 years. Management involves cognitive training, supportive therapy, physical and mental activity, family and caregiver education, and attention to safety. Be aware that if depression is present with dementia, it may manifest as agitation, combativeness, or apathy, and is often misattributed to dementia progression. Of note, the 2016 American Psychiatric Association guidelines provide evidence-based recommendations for antipsychotic use in dementia. Certain medications should be used cautiously in residents with dementia. Antidepressants can be used for depressed mood, low appetite, insomnia, fatigue, irritability, and agitation. High-dose citalopram can improve behaviors but may worsen cognition and prolong QT interval. Use caution when using anticholinergics such as paroxetine, which may cause an increased risk of falls. First- and second-generation antipsychotics can have limited efficacy and increased mortality risk. Use cautiously for delusions, hallucinations, paranoia, and irritability. Valproic acid and carbamazepine are possible options, but with limited evidence and increased mortality risk. Also, avoid using benzodiazepines and anticholinergic medications. Key takeaways from this session: functional disabilities. A significant number of nursing home residents experience mobility limitations, necessitating assistance with daily activities. Post-acute care outcomes. For certain populations, nursing homes can provide post-acute care outcomes comparable to those of acute hospitals. Medicare documentation. Accurate documentation of functional improvements is essential for Medicare reimbursement. Risk factors for placement. Factors such as advanced age, low income, limited social engagement, inadequate family support, and cognitive or functional impairments increase the likelihood of nursing home admission. Team-based care. Collaboration among nurse practitioners, physician assistants, and primary care physicians can reduce hospitalization rates and enhance resident care. Effective communication. Clear communication during transitions between acute and long-term care facilities is vital to prevent issues like incomplete transfer summaries, missing advance directives, and medication discrepancies. Geriatric assessment components includes physical, cognitive, psychological, and social assessments. Medical director responsibilities. Coordinate medical care, set quality standards, ensure compliance, and foster team care. Delirium and dementia management. Monitor delirium for complications, avoid restraints, and use antipsychotics cautiously. Non-pharmacologic management is preferred with dementia, with careful use of medications for specific symptoms. Depression versus dementia. Symptoms can overlap, but there are distinct differences in motivation, cognitive complaints, and skill retention. Thank you for listening to this presentation.